hospice palliative physician and a geriatric fellow. I'm just completing my geriatric fellowship this year, and been asked to do contribute as part of the ECHO team for this topic.
Thanks, Dr. Brogan? Looks like you're still on mute. Just a second here, Dr. Brogan. There you
I
go.
did it. Okay. I'm Kelly Brogan, and I'm currently the section chief for hospice and palliative care at Renown Regional Medical Center. And I'm working in hospice for well over 30 years and palliative care for over 10. And I've had the opportunity to work with a lot of you people, and I miss all of you.
Thanks, Dr. Brogan. Jessica?
Hi, everyone. My name is Jessica Kate. I'm one of the clinical pharmacists at the VA in Reno, and I'm one of the hub members of our palliative ECHO team.
Thanks, Jessica. Dr. McCaleb? Go ahead.
Hi, this is Jonathan McCaleb. I'm a hospice physician here at the VA and a hub team member for the palliative care ECHO.
Thanks, Dr. McCaleb. And Dr. Conwright?
Hi, this is Dr. Conwright. I'm also a hospice palliative medicine physician at the VA and director of the University of Nevada Hospice and Palliative Medicine Fellowship and a hub team member for today's palliative care ECHO.
Thanks, Dr. Conwright. And Sneha?
Hey guys, my name is Neha Sharma. I'm the program coordinator for Project ECHO Nevada. So nice to see you all again.
Thanks, Sneha. All right, so that's our team for the day. And then we'll go out to all of you and ask you to introduce yourselves. So Shalina, do you want to start us off?
Hi, my name is Shalina Laws, and I am a physician at Sutter Roseville Medical Center on the inpatient palliative medicine team and a former UNR HPM fellow.
Thanks, Shalina. Rick? Go ahead, Rick.
Hi, everyone. My name is Rick Obringer. I'm a physician assistant working in orthopedic surgery here in Las Vegas.
Thanks, Rick. Dr. Planenskaya?
I work in urgent care in Las Vegas for Southwest Medical Associates.
Thanks, Dr. Planenskaya. Good to have you. Zara?
Hi, my name is Zara. I'm one of the fellows starting at UNR for hospice and palliative care.
Thanks. Good to have you today. Lorenzo?
Hi, this is Lorenzo Villegas. I'm APRN at the Northern Nevada Correctional Center, and I think last year we just opened our hospice and palliative care. So I'm interested with this topic we have today. Thank you.
Excellent, Lorenzo. Thanks for joining us today. Looks like you've got Fee Neal. Fee, doesn't look like you've joined the audio yet, so make sure you click that little microphone icon in the lower left corner, and we should be able to hear you. Georgie, one of the HPM fellows, could you introduce yourself, please?
Hi, my name is Georgi Esebu. I'm one of the hospice and palliative care fellows.
Thanks, good to have you today. Ashley Knorr? Go ahead, Ashley. I've unmuted you. We should be able to hear you. Maybe no audio there. Guardian Case Manager with Washoe County Public Guardian. Thanks, Ashley. Good to have you. We had Monica, supervisor from REMSA, right in. Monica, good to have you joining us today. Sue is next. Sue, I'll click unmute here, and you might get an alert on your Zoom screen asking to unmute yourself, and then we should be able to hear you. Sue Vaughn from Washoe County Daybreak ADHC. Thanks, Sue. Good to have you. Michelle Moon.
Hi, I am an incoming HPM fellow. I just moved from Washington State, and I'm a neurologist.
Thanks. Wonderful to have you today. Dr. David Bayan. Dr. Bayan, are you there? Yep, go ahead.
Yeah, I had sourdough in my mouth. So, I'm David Bayan. I'm just a regular country doc in White Pine County.
Thanks, Dr. Bayan. Always good to have you joining us. Jenny?
This is Jen Pierce. I am one of the UNR HPM fellows who's just finishing up.
Thanks, Jen. Good to have you joining us today. And I think I see one other trying to join. Dr. Hasabala, but doesn't look like they've joined the session yet. So we'll go ahead and get started. Again, really our goal here is supporting you as practitioners with your own patient cases or questions that you might have about palliative care. So does anybody have anything that they want to ask of the team today? Either, a specific case in mind or just general questions. If you do, please feel free to unmute yourself with the microphone icon on the Zoom toolbar, or you can also write in through the chat box.
So really quickly, I wasn't prepared to ask questions today, but since I see so many wonderful attendings here, I do have a case, if we have time, that I think I'm remembering the major details and kind of maybe get some opinions from the hub team if possible. We had a patient, she's 31 years old, with advanced osteosarcoma that was actually invading into her spine and her right hip. And so she was admitted for pain control, and if I'm remembering correctly, she was on methadone, 75 milligrams TID, oxycodone, 60 milligrams for her breakthrough pain, and she was using that about every 3 to 4 hours. She also had a fentanyl patch on of 150 mics, and these were her home meds. And then she came in extreme pain. The hospital has put her on a dilaudid drip, which they titrated up to initially 5 milligrams an hour and kept going up to 10 milligrams an hour. And she's wide awake, still in a lot of pain. We were consulted, and initially we did go up on her methadone. We went up on her fentanyl. I'm trying to remember what we kind of maxed it out at. At 10 milligrams of IV dilaudid an hour, I felt like that wasn't helping her. The month before, it had helped her, and our team wasn't involved then, but they were able to use that and convert it over to POs and her transdermal and get her home. But I felt like if she wasn't getting pain relief with 10 milligrams of dilaudid, we needed to switch her to something else. So we rotated her to fentanyl, a drip, and we couldn't do that on the floor, so we put her in the ICU, which also gave us the opportunity to use ketamine IV. So with the fentanyl, she was on up to around 300 mics an hour. And then with the ketamine, I'm trying to remember what what the high was on that. I think it was around, I don't remember exactly, but she was on a lot of ketamine. And we were having a really, really hard time controlling her pain. The problem also was that keeping it in line with her goals. Her goals were to return home, not be on hospice, to be awake, alert, and interactive with her 7-year-old son. So, if I was just to do palliative sedation and make her really comfortable, that certainly would have made our job much easier, but that was not in line with her goals. So even with the increase in the fentanyl patches, I think we ended up going up to 300. She was in the hospital for about 10 to 14 days. And then the oxycodone, we didn't increase. And then the methadone, we did increase. I think she ended up leaving with methadone 95 TID. And we got anesthesia involved. They felt that they couldn't do anything for her that would allow her to go home with some sort of epidural. We got Radonc involved. And her ultimate goal was to try to get down to San Diego for proton beam therapy, but so we initially didn't do radiation because they felt that that might actually prevent her from getting the proton beam in the future. But then oncology just said, I don't think that's going to happen anyways, getting you down to San Diego. So she went through with maybe 5 of her radiation oncology treatments of external beam, but it was really painful for her. So then she started refusing. We don't have a pain service here or an ability to put in a pain pump. So we transferred her to Stanford, where pain management along with neurosurgery, because it had invaded her spine, were putting in a pain pump. And so I just think about this case and that, what else could I have done for her with my resources? What other medicines? I looked into lidocaine. Pharmacy was going to allow us to do lidocaine infusion, but, that wasn't going to get her home. That might get her through a radiation treatment or, maybe one night, but, and I don't know maybe what other medicines. I mean, she's on a lot of pain medicines. And so the ICU team and oncology were also concerned sending her home on some of these meds with the fear of her overdosing. She's not on hospice. That wasn't, she wanted to continue to see if maybe she could get down to San Diego. So other than transferring her, does anyone else have any ideas of maybe what we could have done for this woman? Other medicines that, we weren't thinking about. And then I also talked to IR about like cryoablation or something along those lines. And they said no, that her tumor was too big. They didn't feel that she would get really benefit from it. And we put her on other medicines like a bisphosphonate. So I started that. I also started duloxetine because she did have depression and a lot of neuropathic pain. She was on steroids. Trying to think of what else we did for her. But, any other ideas from, I know some of the most brilliant minds on the West Coast.
Yeah, great presentation, Shalina. Thank you so much for presenting that case to us today. So we'll open it up for what we call our clarifying questions. So it's your opportunity to ask some questions about this case, get a little bit more information, help you digest it a little bit more, and then we'll move on to some recommendations. So one question already that came in from Rick, he's asking, does she have Narcan readily available?
At home she does, yes. Yeah, our patients do go home with that. And she lived at home with her husband, who's very supportive caregiver. So they did have that.
Okay. Other questions?
Was oral ketamine discussed at all?
Yeah, we did. That's thank you, Jessica. That's a really good point. Yes, we did start her on oral ketamine. So we put her on the IV, and then I had to get it approved through pharmacy because initially they told me no. And then after a couple of days, I managed to change their mind. And so yes, we did put her on oral ketamine, and we were titrating that up at the time of her transfer to Stanford.
With the infusion of ketamine that you were using, did you find that, after 24 hours when you were reassessing, was there, I take it, there was still the same amount of pain, there was no change in like the doses you were able to use on any of the other medications, were there?
So she would kind of wax and wane. She would have periods where she would do really well, and then periods where, it was out of control. Part of it was also that we learned kind of in this process, some of it was a little psychological too. Like if you went down on her drips, she would kind of freak out. But when you actually asked her, like, what's the level of your pain? She would tell you a 5, what's appropriate for going home, a 4. But she would get a lot of anxiety around, decreasing some of these drips because she was really afraid of being in, having some of those pain crises. I don't feel that the ketamine, it didn't work as well as I was hoping it was going to.
Yeah.
But, I think that she did get some relief. But we were also doing so many things at once that it's kind of hard to tell. Maybe was it the ketamine? What we switched her to fentanyl, the IV, the same day that we started the ketamine. So, you know, I'm not entirely sure. You know, and then we started her radiation treatments the same time. So
Sure.
it's kind of hard to say.
So, can I say something? I don't even know how this works.
Yeah, go ahead, Dr. Brogan.
Oh, okay. So, the case that you're describing are some of the greatest nightmares I've ever experienced. Unfortunately, the ones that I dealt with were children. So I think that in general, you did a really remarkably excellent job. A couple of things that I would think of, and you kind of stated it at the end there, is the anxiety component. So this lady's opioid receptors, you could throw anything you want at them, and they are already so amped up that opioids in and of themselves are not going to manage her pain. Whether it's ketamine, methadone, nothing. And that's my experience with this kind of cancer, and then the anxiety that's associated with it. And I'm a strong proponent of benzodiazepines, and my favorite is clonazepam in this kind of a situation, clonazepam and Valium. Clonazepam being the most fat soluble, therefore having a benefit for neuropathic pain. Valium, you know, I'm pretty sure there's no literature, but I think in general, of all the benzos, we have a pharmacist here, maybe she can help out, but just experientially, Valium seems to just make people feel okay. Although clonazepam, as we know, it's used for bipolar disorder and other things like that. So I would have juggled those two things. The only other suggestion is, and it's unfortunate, but the thing I would have done sooner if I could is get that intrathecal pump in her as soon as possible so that you could maximize her adjuvant, her oral adjuvants.
Yeah, actually, David brings up a good point too, and I was thinking about it early on with the use of the IV pain meds, thinking about hyperalgesia as a kind of a superimposed entity
Right.
that could be, you know, manifesting this way. It's kind of like turning a volume knob without any more indicators.
Most
Yeah.
definitely. And so, yes, and I was thinking maybe the ketamine might help with that as well. In terms of the benzos, she came in from home on Valium 7.5 TID. So I didn't go up on that. My concern was that, you know, her goal is to get home. She's on, you know, benzos and opioids, and, you know, concerned that she's going to overdose too. But yeah, I certainly, I didn't think about clonazepam, and we could have definitely have tried that or gone up on some of her benzos, especially in the inpatient setting. You know, it is safer. She's in the ICU. She's being monitored really closely, as opposed to at home.
And I might have missed it. Where was the pain exactly? Was it just generalized, or was it mainly in the back spine area?
It was mainly on her right, kind of right hip and back. So she preferred to lay on her left side. So that tumor had kind of taken over her right hip area, but then had also invaded her sacrum and like L4, L5-ish regions.
And she was still mobile, ambulatory?
She was ambulatory, yeah, with pain. But yeah, she was not bedbound.
So not to minimize her the validity of her pain in any way, shape, or form, but this is a young woman with a young child, and psychosocial spiritual distress has got to be aggravating this considerably.
Most definitely. It was certainly a team effort. You know, myself on our team, we also have nurses, social workers, and chaplains on our palliative medicine team 7 days a week. So everyone, yes, was involved in her care. And so that was a huge part of it. She has a 7-year-old son and a husband, and most definitely.
So I'd like to point. Oh,
No, go ahead.
Dr. Essebois is
I'm
about
sorry,
to
go
speak
ahead.
up. And I just want to give Dr. Essebois his due. He is our hospice fellow, but he is a pain fellowship trained physician from Wake Forest University. So he has some very salient, helpful things to say. So go ahead, Dr. Essebois.
I was just going to say that I think I agree with Dr. Brogan, and intrathecal drug delivery was probably the most reasonable way to treat this patient's pain. The other thing that comes to mind, since most of the pain was in the hip region, I think anterior hip denervation could have been helpful, and that is done with a cooled radiofrequency ablation. I'm not sure if that was available to you guys or not.
Sorry, question, some other questions. Would tramadol give some benefit?
For me, and I would love to hear the panel, I'm not a big tramadol person. It lowers the seizure threshold. To me, it's not very strong. That, certainly wouldn't be my go-to, but I am interested to hear what other people have to say.
Yeah, I see Dr. Milo's comment here as well. Given all that she's been given, I doubt tramadol would show much added effect. Rick, did you have something?
I agree. I only wanted to add because just to drive home Dr. Brogan's initial point, which was that the receptor saturation is at such a level that it's unlikely any opioids would have made any difference. That being said, just looking at it in retroscope sort of fashion, I did have a similar patient to this that I managed with Dr. Brogan many years ago, and actually it was my first time ever using IV methadone. And I don't know if you remember that, Dr. Brogan, or if you've had the opportunity to use it since, but I was just going to say that it's not very frequently recommended, but just the case profile, Shalina, that you presented was actually a 30-year-old female with advanced cervical cancer and uncontrolled cancer-related pain syndrome with children at home and several other similar psychosocial complexities. And I do recall that case most specifically because Dr. Brogan was able to make those recommendations, and we were able to get that particular patient's pain under better control. So I know that there's a very narrow, if not almost absent window for use of methadone as an IV intervention, but it's not undescribed.
Thank you. Yeah, I don't know if our pharmacy allows that, but I should definitely ask.
Yeah, that is a tough case.
Thank you for listening and giving all of your recommendations. And, I hope the patient is doing well with her pump, but I really appreciate everyone's recommendations.
Thank you for that case.
I'm just curious, she may be way past this point, and this may be a little bit out there. Has any consideration been given for surgical referral for a possible hemipelvectomy?
Yeah, they did. She was actually seen at the Mayo Clinic for that. And they discussed just that surgery, but felt that she wasn't a very good candidate for that because of how extensive the tumor was. So the hope was that maybe with some proton beam and also some chemotherapy that they could shrink that tumor, and then maybe she could go back to Mayo Clinic. But yes, she was seen at Mayo for that particular surgery. Sorry for taking half the echo.
No problem. This is really what it's all about. Yeah, absolutely. All right, I think we'll get started. Then I'll pull up the slides here.
Yeah, I think Dr. Brogan just got logged off, and so she's gonna try the link again.
All right. All right, so this is our disclaimer, just letting you know that we do record and post all of these sessions. We do cut out any of the case presentation portion. It's just going to be this didactic portion that we post. And then Shalina did a great job of not disclosing any protected health information about that case. So this is our team for the palliative care echo whom you met earlier. This is our disclosure policy, just letting you know that none of the speakers today have any disclosures. And with that, I'll turn it over to Dr. Mila.
All right, thank you, Troy. Just getting my screens all set up. They start flickering and everything moves. Anyways, so we're here to learn and present a case on nausea and vomiting in a palliative care and hospice setting. Some basic learning objectives. Want to be able to identify a cause or the likely cause of what's causing these symptoms, develop a plan of approach for treatment, and then decide on medications which would be most appropriate for that specific cause. I got a text from Dr. Brogan, says she should be back on in about 5 minutes. They just shut off her internet. And so yeah, if she's not back in time, I can just read her portions as well and then have her jump in when she's ready. So we've got a case here, and I figured this is, and I know Dr. Brogan wanted to talk about this section, and I'll probably let her chime in when she gets back on. But so we have a case to present, and this is a case, it's framed around a case that I had to deal with Dr. Brogan. This particular case showcases a bunch of different things. One of the things we wanted to really show is that nausea as an entity oftentimes is one of those unfortunate things that just happen when patients are in the hospital or at home receiving therapy on medications, and it's kind of just accepted that sometimes it happens. But the issue is that we don't oftentimes, when we're trying to figure out the root cause of what's ailing the patient, this particular symptom may go not unnoticed, but not responded to in a with as much gusto as the primary symptoms. And the reason why this is important is because when someone's nauseous, and I'm sure everyone has been nauseous in one sort of capacity in various degrees, but it's kind of a background unpleasantness, and it can, and with some patients it can come to the forefront and make their whole entire experience of either daily life or hospital stay completely miserable. This is something that we see with our patients constantly, and especially cancer patients is a known entity that around 60% or 70% of patients have nausea and sometimes associated vomiting with it. And to not give it the amount of due it's needed and to treat it as rigorously as we would any other symptom would be doing less justice for the patients. So that being said, I'm going to start reading this case that we have. It's by Mr. S.
We've got Dr. Brogan back on as well.
Oh, yay. Okay.
Sorry about that, guys. Getting a
No
little work done at my house. So want to thank Dr. Mila for doing all the work. I'm just here to chit chat. Anyway, the case is Mrs. S. She's a 64-year-old woman with admitted with severe abdominal pain. She was recently diagnosed with metastatic pancreatic carcinoma, which involved the head of the pancreas. She had significant pain to begin with, and she underwent a celiac plexus block, and that had a significant benefit in relieving her pain. However, shortly thereafter, she developed intractable nausea associated with vomiting and diarrhea. Her medical team was giving her ondansetron around the clock with little effect. One thing that I do kind of want to throw out here with regard to treatment of nausea is that, like pain, you want to, it's multimodal in terms of treating it, or certainly multi-medication, and you want to give medication routinely rather than just PRN. And as we go through the talk, Dr. Milo, I'm sure we'll talk more about using different more than one medication to target the problem. Anyway, she was having significant difficulty keeping food and medications down. She now required that her oral medications be switched to IV. She also had to have, multiple IVs replaced, as well as labs drawn, because she wasn't eating and she was vomiting. She stated to her team that she was exhausted and she felt like she was dying. She is weak, and due to the constant sensation of nausea and vomiting, she could not participate in anything meaningful in her daily life, and she was unable to participate in therapies. And then the palliative care team was consulted. So when initially I turned my mute off because I hope you guys aren't hearing all the noise going on, but can you hear that? No? Okay, good. So basically, nausea is caused not either by the disease itself, like for instance, in pancreatic cancer, the inflammatory process can affect the vagus nerve, and the vagus nerve itself has both sympathetic, parasympathetic, and motor function. So people can have both pain and nausea and not be able to distinguish between the two symptoms, like they go hand in hand. So they can be disease related, but certainly the things that we do to people can make them feel nauseated as well. I'd like to make some jokes, but I won't. I'll try to be appropriate today. So nausea alone, in the absence of vomiting, can certainly cause malnutrition, dehydration, and the inability to take medications. But even more than that, nausea can affect people's activities of daily living, affect their quality of life, and cause them to not be involved in life. And as a consequence, there's significant suffering from the nausea itself, suffering from change from the sequela of vomiting, such as the weight loss, the physical appearances that may occur, and then the things that we do to people that cause the nausea can also cause significant suffering. Next slide. So when we're identifying what is the cause, everybody knows the PQRST, formula for assessing pain. And I feel like you can basically use that same format for assessing nausea. You really need to take a very detailed history regarding timing, duration, what are the precipitating and alleviating factors, etc. We all know how to do that. Then you want to make sure you do a medication reconciliation. The simple, so someone might be on a medication that causes them to have nausea every day, low-grade nausea such as Zoloft. They were just started on Zoloft, and then we started them on a not significantly emetogenic chemotherapy, and suddenly they're extremely nauseated. So you really have to look at all aspects of what is causing their nausea. And as we go along, also talking about anxiety, stress. I think just about most of us through this whole COVID thing have probably been nauseated off and on just from anxiety alone. Not eating, not being able to eat, those things can worsen nausea. Certainly, you need to make sure that you've reviewed recent procedures or therapies, such as chemo, radiation, and surgery. And then you want to also take into consideration electrolytes such as calcium, et cetera, and other electrolytes or abnormalities that can cause nausea. I will mute.
All right, so I was just going to discuss the medications. I'm one of the pharmacists again on the hub team, and Dr. Mila put the table together, and it kind of just includes the different classes of medications and the drugs that are in them and the different receptors that they hit. The most important thing, kind of as Dr. Brogan had said, was looking for the etiology and trying to treat along those lines. Unfortunately, sometimes when we're talking about end-of-life palliative care, we're maybe not going to be looking for those things at all times. And so really using a multimodal approach, which can include using more than one medication to kind of get different mechanisms to hit different things, and looking really for the response, and knowing that maybe sometimes as needed use is not the best, using them scheduled and kind of identifying triggering factors to try to use medications before those, when we're talking about eating or pain, things like that, is really important. So while I'm not really going to go through each of these medications, this is kind of a good reference, especially when we're talking about side effects. We, of course, are trying to improve the quality of life of our patients, and some of these medications unfortunately do have some side effects that can be bothersome to some, to the extent where they, it's the risk benefit when we're trying to manage their nausea and vomiting. So the biggest ones we can see throughout most of these medications is sedation or drowsiness, especially with our dopamine agonists and our antihistamines and the antipsychotics. We'll see those as well. QTC prolongation can be seen throughout some of the different medication classes, which we're probably not going to be monitoring, but just thinking about some of the other medications that they might be on, some pain medications, other meds that also can cause QTC prolongation. So we're definitely not wanting to hasten their death by putting them in a life-threatening arrhythmia. So just thinking about that, and a lot of times that can be dose related as well. Other things are anticholinergic side effects, so dry mouth, constipation, dry eyes, which can also be very bothersome. So it's kind of that risk-benefit discussion when we're talking about the side effects. Do we want to try to manage some of the side effects with other medications? Typically, I try to avoid that, but if it's going to help improve their quality of life, then that can be something that can be considered as well. Some kind of pearls related to some of these medications quickly. We really want to avoid Reglan or the metoclopramide if they have a complete GI obstruction. So you want to be looking for those things if you are concerned with tumor burden, constipation, things like that. And then the dopamine agonists and the prokinetics, so the metoclopramide, can also cause dystonia and movement side effects. So using Benadryl if that's indicated to kind of manage those things if it's controlling their nausea and vomiting. Other medications that you don't see on this list, a big one that we use is dexamethasone. It's useful, mostly we use it in nausea and vomiting associated with chemotherapy. So it's part of regimens for pre-chemotherapy and then extended beyond chemotherapy as well. And we also do sometimes use it with kind of tumor burden, GI, also brain tumors, things like that, where it can be not just for nausea and vomiting, but also for some pain management as well. And then benzos, which Dr. Brogan had alluded to, kind of managing that anxiety as well, and that can be a really effective medication for that. They're not really known to be very good antiemetics, but if you're managing the anxiety associated with the nausea and vomiting, that can be really helpful. And especially sometimes those side effects that are associated with some of the medications like akathisia with dexamethasone and metoclopramide as well. And then lastly, which I think will commonly come up, is the cannabinoids, are both medical marijuana and then our pharmacy medications such as dronabinol. And they can be given to people with refractory nausea and vomiting. We really try to limit their use, especially in the VA, as I'm sure a lot of the physicians on the call know. And then medical marijuana, unfortunately, has really a lack of literature because of the controlled nature of the medication. So we don't generally recommend that, but that can, kind of differ depending on practice and kind of your experience with it as well. So it's a very quick, abridged discussion of some of the antiemetics that we can use in palliative care. And then I think Dr. Essebois did also just mention the aprepitant, which is the NK1 receptor antagonist, which we do use in chemotherapy. We didn't include it here because we were kind of talking specifically about more of like that palliative care, but it is a very effective medication for that chemotherapy-induced nausea and vomiting as well. Thank you, guys.
Thank you, Jessica. So when looking at how to approach treatment, there are some people that say that, once you discern a cause, you can go by receptor, what medication hits what receptor. There's some literature that may support it. I find that going in a stepwise fashion, using a single agent first to get a good amount of relief first has helped me kind of streamline my process and made things a little bit easier to made the process a little less murky. So this particular slide is just my simplified version without the dosages and stuff from the Cleveland Clinic single agent protocol. And essentially what you're doing is you're ruling out reversible causes. And so we go back to the earlier slides where it was when we're talking about medication reconciliation. You look at medications that may or not be able to be removed, like digoxin, iron, statins, NSAIDs. All of these can cause nausea. There's some opioids will cause gastric slowing, constipation. And so what we like to do is see what we can reverse from the start. And then we get imaging to see if there's an obstructive process going on. And basically through chart review, you'll get a general idea of where to go with your treatment. If it is, we talked about dexamethasone with malignancies, sometimes not just used for nausea, vomiting, but a lot of time our CNS malignancies will have shown multiple different benefits from the use of dexamethasone. Reglan has been, at least in this protocol, has been kind of a first-line agent, and typically it's something you'd schedule around the clock and not give PRN, as we've said multiple times before. As far as enemas are concerned, if the patient has constipation, there are ways to kind of approach relieving that constipation. You want to make sure that there's nothing that precludes the use of an enema, but personally, I like using enemas as more of a last resort if the other medications aren't really working as well. Sometimes in hospice patients, you'll get people who don't have very good PO intake, who get constipated, are nauseous, and it's a cycle of putting medications in. Sometimes it just takes some hydration up front, some Miralax, and they're able to relieve that constipation and thereby relieve their nausea as well. Home remedies, even such as something like prune juice, will help them as well. And I feel like in the scheme of all these medications, we forget there's some remedies that are almost just as effective. So we go down this list, and we said before, entities like obstruction, like complete GI obstruction, partial, near total obstruction, you want to avoid using Reglan. But a lot of times that'll take either studies, other imaging to really help identify that. It's hard to say. Sometimes patients who are passing gas may or may not have a partial near total obstruction. If it's complete, typically you won't be seeing that as much. And so after this slide, we're going to continue on with that case and then walk through the treatment process that we went through of how we approach that case. So let's see here. Dr. Brogan, did you want to read this?
Yeah, sure. I'll just go through this. So I think the other part is about just how much nausea can affect quality of life. sometimes people talk about pain, 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 and they forget just how awful nausea is. So she has, since the celiac plexus block, she has lost 12 pounds, and now she's refusing to join her family at meals and refuses to have her family around for any length of time. She explains that it's because she doesn't know when she's going to vomit or start retching, and she doesn't want to be seen in that kind of a state. Mrs. S's abdomen has now become distended, and nursing has reported that she has not had a bowel movement in about 5 days. She reports that the nausea is 10 times worse than any pain she has ever experienced, and she can't keep living like this.
So hearing that, it's worrisome. So we want to be able to find out what the cause of her issue is and relieve that nausea as soon as possible. So if we go down the flow chart, we look for reversible causes. So in this particular patient, we did an x-ray of the abdomen, and at the same time we're thinking about a lot of the therapies that have just come before. There was no recent chemotherapy in her treatment regimen up until the time she came here, but she did get a celiac plexus block, and celiac plexus also are known for a side effect, which is causing diarrhea. And so that's something just to keep in mind as we move on with what kind of therapy we're going to try to tailor this to. We look at medications, didn't really see any medications that would contribute to her nausea. Nothing recently added that would change her status. But because she has this tumor burden, this pancreatic mass at the head, we think about its proximity to its surrounding structures, which in this case would be bowel, duodenum, things like that. And because it has metastasized, you start thinking about, invasion and other spread. Next slide, please. So I'm thinking of tumor proximity. Could this be causing obstruction? She was passing gas, but hasn't had a bowel movement in multiple days, and that's worrisome. So to get some, before we were getting our imaging, we started Reglan just because we're thinking, she's passing gas, there's less likely to be a total obstruction, and so at least maybe this can afford her some relief. She does get some relief from scheduling Reglan. I believe it's Q8, 10 milligrams IV, but it was temporary. And so next slide. So imaging shows us a near total bowel obstruction. And so right then and there, we stop our Reglan, as it's not really recommended in these types of patients. And looking back at the flow chart, we're taking kind of the left-hand side. And so choosing IV octreotide in this case is one of our choices because it also doubles as treatment for the diarrhea of the celiac plexus block. And so starting octreotide and dexamethasone together showed marked relief of her symptoms. Over the next 2 days, Mrs. S improves, nausea and vomiting are minimal, and her diarrhea has more or less stopped. Issue is we can't send her home on an IV regimen. And so we started olanzapine, and through her times when she was taken off of octreotide, that showed that it ended up helping her nausea significantly. And that was continued as her IV medications were discontinued. Dr. Brogan?
Sure. So just to kind of wrap it up, much of this slide has already been talked about, but I'll go over it again. The sort of the quick tips of nausea is always think about anticipatory nausea, and remember that human beings have a lot of anxiety when they're sick. And then chemotherapy related. In times where I think of them as triads, so triads of symptoms. So if the person has associated weight loss, depressed mood, and sleep issues, think of mirtazapine. If they're getting highly emetogenic chemotherapy and they have, anxiety and sleep issues, think of olanzapine. I know that it has some side effects long term, but you got to realize that our patients, some of them aren't going to be around for a long time, and they're very, very miserable. And I've had amazing success with olanzapine 2.5 milligrams at night or 2.5 milligrams twice a day. It can be given in a dissolving tablet, oral dissolving tablet, and something that the patient can manage at home. And then you have always your serotonin agonists, but as we saw, they have some considerable side effects, specifically the QT prolongation. And unfortunately, people who are actively receiving treatment are also on many other agents that do the same thing. NK1 receptor antagonists, obviously for highly emetogenic chemotherapy, but just FYI, olanzapine also blocks that receptor. And you can't, I don't think, Prepotent is extremely expensive.
Yeah.
Dexamethasone, huh?
No, I was just agreeing with you. Yeah.
Yeah. So dexamethasone, that drug it's a great drug. Obviously, we have long-term side effects, but I think that, dexamethasone can be given for abdominal carcinomatosis, for brain metastasis. It can be given in a 7-day burst and then stopped. There's a lot of different ways to dose dexamethasone. I think Jessica brought that up. There's one last thing that I realized that we didn't put it all on this chart, and that is be sure to look for esophagitis and gastritis, reasons for people to have that. And, so Candida or just stress gastritis, and make sure they're on PPIs as appropriate. And we know that PPIs cause a lot of side effects, but certainly that's something that I think is sometimes missed.
Excellent. Great information, Dr. Myla and Dr. Brogan. Thank you so much. So yeah, we'll open it up right now. We've got a few minutes left for questions from the group. Does anybody have anything that they'd like to ask?
Well, what was the result when I got cut off? Did we decide that Dr. Laws did a great job given her circumstances?
Yeah. No, it was a really good case.
Yeah.
Dr. Conrad? You're still on mute. Just a second here. Go ahead.
So Dr. Laws, I was curious, was the payment mechanism possible to consider an intrathecal infusion for your patient?
Dr. Conrad, did you ask the payment method?
Well, would it have theoretically been possible to use an intrathecal infusion method to address your patient's pain?
I think not at Sutter Roseville so much. So anesthesia initially said, well, maybe we could try it, but that isn't going to get her home. So we can place a pump, but we can't manage that as an outpatient. So that wasn't really in line with the goals from what anesthesia could do in particular. Was very limited for us. So we transferred her to Stanford so that she could get like an implantable pump that she could go home with. So what we could do at Sutter Roseville, she couldn't go home with. But we did transfer her to Stanford so that she could get intrathecal. Mm-hmm.
Perfect.
Yeah. Unfortunately, sometimes you're also limited by somebody's insurance. So, we had initially, sent it out to UC Davis and other facilities as well. But Stanford was the one who accepted her insurance, and she had Sutter insurance, but which also worked out. She had a second oncologist at Stanford as well. So, you know, she was somewhat familiar. It was just unfortunate that it was so far away, but we were able to arrange it so that she could get the pump at Stanford, and UC Davis would manage it and refill it. So there was a lot of finagling going on.
A lot of coordination, yeah.
A lot of coordination, yeah.
Wow.
Any other last thoughts or comments?
I would just like to say thank you for giving a lecture on this topic. I think oftentimes nausea vomiting does get overlooked. You know, maybe in the last 10 to 15, 20 years, everybody's focused on pain, 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 pain. But for a lot of people, nausea vomiting is just as miserable. So, you know, thank you. It's not a one size fits all, and you know, it certainly is something that needs to be approached, you know, more in a stepwise fashion. I feel that from what I've seen, both from emergency medicine and kind of the hospitalist side of things, is that they just want to throw Zofran or Dansitron at everything and wonder why their patients are still nauseous. And Zofran doesn't fix everything. It has side effects. It gives you headaches. It gives you constipation. You know, it's not this miracle drug that people want it to be. And I think maybe some physicians are afraid of some of the other side effects that other drugs, you know, might cause. But you know, we have some other wonderful, you know, medicines out there besides Zofran, which, you know, has its place in palliative medicine. But
I agree totally.
we certainly need to think outside the box. And that's one of the things that our wonderful specialty can do and help our colleagues in determining, like Dr. Milo was saying, you know, the root cause, trying to go after that in a stepwise approach. And I thought that what Jessica said was also really nice, in that trying to recognize things that can trigger it and prevent those as well. And I think that that's, you know, really important, that anticipatory, that anxiety portion of nausea vomiting is very, very real. But we should also let patients know that just because they have that, it doesn't make them weaker as a person. You know, we're all human beings. We can all have that, and so they shouldn't feel weaker because we're saying that there's an anxiety component or an anticipatory component to their nausea vomiting. But at the same time, we should also take that sort of nausea vomiting and treat it just as seriously, and not, you know, just tell them it's in their head, or, you know, try to calm down, because it's very real and it's very miserable.
Absolutely. I too was guilty as a resident of just going to knee-jerking to Zofran the whole time. And I think a lot of times it's a lack of awareness of what the other medications can do. And, you know, sometimes a lot of side effects are going to be across the board, but some might just work better than others. And so once I kind of realized that, it kind of helped me step out of that mindset of just what the culture of the hospital was just Zofran. And so it's interesting. I mean, it's, you know, you sometimes you don't know how they're going to react, but there's literature showing certain things like Reglan, even though it does cause some noticeable side effects, it does work pretty effectively for certain types of nausea. And so, yeah, it's a fascinating topic, and that I was previously admittedly ignorant to in its full capacity before.
I just want to echo and thank Shalina for your comments. And I only wanted to add one other thing, and that is that first and foremost, I never thought I'd be in a position to say, you know, when I was in training, since that was only like 10 years ago, but I guess that was a while back. But one of the things that strikes me is part of the reason this Ondansetron thing becomes the knee jerk is because of standardized order sets. And because we're not encouraged to write our own orders and sit and think out a plan on a blank piece of paper from the top to the bottom, setting up orders for a patient, we are presented with a series of computer-generated orders, and when the computer-generated order set comes up, half the time the only one that's made available is the ondansetron. So it just sticks that in our mind as, well, I guess I better choose that for my patient because that's me addressing nausea. So sorry, I didn't, not to add anything negative, but I mean, that's just my take on it.
It was on my order sheets when I'd admit patients when I was an intern. Looking back, like when you're out of that stress of being a resident or in that training, it's interesting to see why things are done, like the normal things or what's considered normal. And so now being able to think a little more independently, be able to try other medications that may be more suitable.
All right, I think we'll wrap up for today. We're a little bit over time, so thank you so much, everybody, for joining us today. Actually, one comment here from Lorenzo. Our palliative hospice program in the correctional is still new. We have very limited resources in our formulary to use, and this presentation helps a lot. We have olanzapine and mirtazapine in our formulary. Thanks, Lorenzo. All right, so we'll wrap up for the day. I sent a couple things to the chat. The first is a link to our website where you can find the slides from today's session. So if you scroll down a little ways, you'll find today's date. And then this is a link here. This will download the slides for you. And then there's a link here. I also sent that through the chat box to claim AMA PRA Category 1 or nursing credit for today's session. And then our next session is going to be on July 17th from 12 to 1. We're going to be looking at cancer patient challenges with pain and payment. So we hope you'll join us for that next session. Again, July 17th at noon. Thank you to Dr. Mila and Dr. Brogan for a great presentation today. Thank you, Shalina, for a great case presentation and discussion through the session today. Appreciate everybody's participation, and we hope to see you again next time. Thanks, everyone. Take care.
Thank you, everyone. We miss you, Shalina.
Miss you guys too.
Thank you. Bye-bye.
Thanks, everyone. Hub team, if we can stay on for just a couple minutes.
Of course.
Should I get off?
Are you okay if I leave?
Yeah, Dr. Brogan, Dr. Mila, you can take off.
Thanks, Dr. Brogan.
Okay,
Yes, thank you, Dr.
Bye-bye.
Brogan and Mila.
We'll see you guys.
Okay, you're welcome.
How do I exit this line?